Hello, everyone, and welcome to another Unfiltered podcast. And we have a special couple of ladies with us today. Kelly Donahue and Jackie Curry are the directors of operations for K&K. Jackie is the lead and Kelly is the assistant. And they have a burr in their saddle, which is what usually Cindy has that starts these Unfiltered podcasts. But this is about the intake process. This is about what information that you get from the providers, from the hospital, from skilled nursing, all these places that you get patients from. What kind of information do those people bring with them, and how important it is that they bring everything? And I say that because we often in home health can remember those days where we got a name and a location to go see a patient. And that was all we would get. And we would get to the house and we'd discover what we discovered. Well, those times have changed, especially with EMRs. It is not appropriate to go on a name and a location anymore. There's risk involved with that. We're hearing a lot more about workplace violence in home health. There's a lot of different things that make you want to be as prepared as you can be. Now, ladies, intake. How many times a day do you, Kelly, I'll use you first. How many times a day do you have to contact one of our partner agencies about something that is missing on an intake for a patient?
Numerous. In one word, numerous. It's important they have all of that information from the beginning.
And that information includes what? What items are you looking for as a certified coder and as one of the people that is in charge of the quality for K&K Healthcare Solutions? What kinds of stuff are you looking for on that intake?
Face to face, the diagnosis that's driving your home care reasoning, discharge summaries, a lot of detailed information that a coder needs in order to get started. Without that, it causes a lot of delays all around for all of us.
And home health is a logistics company at its core. And I always have to give credit to Lori Apple from Corso Care when I saw her at a Decision Health Coding Conference, and she said, at its fundamental core, home health is a logistics company. And logistics means you have to get the information. A manufacturer would never, in a million years, just load a truck and arbitrarily send it to a customer if they said, hey, we like that product. No, you're going to have a form in triplicate. You're going to have a level of a hierarchy of signatures that have to happen. You're going to have confirmed payment, and you're going to know exactly what that customer is asking for. And Jackie, what would you say is the most missing thing on that intake that just frustrates you on the daily? And I heard a rumor it might be on your tombstone.
Well, the face to face. That's the whole lack of understanding of what the face to face is. The face to face does not have to be within one document, but it must have three key items: your primary diagnosis, disease process for the reason for referral to home health, the physician attestation, which is usually found within a physician encounter note, and the physician addressing why the patient is homebound. Not just gait instability, but what disease process is driving that homebound status. But I'm going to piggyback on the back of Kelly's note about the documents needed. Just because you get those documents doesn't mean they're going to be of much help, because certain information's got to be there. The physician's signature has to be there. Besides the physician's signature, the diagnosis itself, not symptoms. I was talking to Kelly earlier before we did this. It can't be nausea and vomiting and diarrhea, gait instability, falls, muscle weakness, and we can go on and on and on of the symptom codes. We need to know, is it recovery from colitis? Okay, if they have colitis, they're going to have the nausea, vomiting, and diarrhea. So we need that disease process. If they're falls, do they have Parkinson's? Do they have dementia? What disease process is driving those symptoms that you're being referred for? And the worst one of all, wounds. The referral stating wound care, left leg. And Kelly, you want to piggyback on that one?
Yeah. Wounds are a really big one too. Just because maybe a nurse mentions it, we got to have that documentation. And that's a big thing. We may not have, physician documentation to go along with that wound, and we need that. We can't just go by what the clinician has.
We have to have the etiology.
Etiology.
Yeah.
We have to
Yeah.
know where that wound came from and what status it is right now. So, for example, if you have a arterial wound on a lower leg, that can become a diabetic wound over time, especially if it's non-healing. There's all kinds of aspects of wound care that are specified to not only just the type of wound and where it's located and what the etiology is and what the stage of it is. You also need to know what is the morphology. Where did it come from? Is it not healing because of diabetes? Is it not healing because of circulatory problems? What is the reasoning for that wound? And one thing I want to mention about that's the wound you know about,
Mhm.
right? Because
Yes.
oftentimes every clinician listening to this has had the experience of walking into a house knowing about a large wound that needed a wound vac in a certain area, only to discover 3 other wounds. And in that case, what would you recommend that the clinician do at that moment in time when they see those?
They should get on the phone with the
Yes.
physician and get the wound care orders
Mhm.
along with confirmed etiology.
Yes.
Yes,
Um,
they can stage them though. A pressure wound or a traumatic wound, they can tell
they
you
can
the depth.
they can upstage, but the
Yeah,
physician has to confirm initially. But he can say unspecified, and then the clinician upstages it.
right. So if you're looking at a wound, you can say the what it's presenting to you. Do you see, the fat layer? Do you see just the skin layer gone? Those kinds of things the intake clinician can assess. However, they cannot assess where the birth or the origin story of that wound, if you will. Those of you that like superhero movies, the origin story of that wound is super important to your coders and your reviewers. And what is about to change in October? Every year in October we get a change. And what is happening this year, ladies? We're having fun with this.
Close to 500 new codes, but the vast majority of them are dealing with wounds.
Ding. And the reasoning behind that is CMS pays a little extra for wound cases. They know that they're expensive. They know that they have an extra cost on the agencies. And so that documentation about the wounds, let's bring that to the front. Probably the number one thing you need if you're going to get an accurate face to face. CMS gives you 5 days from the day you go out and meet that patient and see what they look like or what they're presenting to you as a home health clinician. They give you 5 days to gather new information, to get all those things together and have it on the original Start of Care Oasis. And that Start of Care Oasis is going to set your payment for the 30 days to 60 days that you're going to see this patient. So tell me about what kind of delays happen when that information is not readily available.
We have to get back, to the agency, and if we put that chart on hold, that chart just sits there. That's money, the agency isn't getting either, because we have to verify documentation. We have to verify all of that stuff with the physician. Sometimes it takes a while for the physician to get back to us. It could sit there. It's money sitting.
And I'm going to add on to that also clinician lack of understanding and QA office not understanding that we're not asking for the clinician to confirm it. The
Mhm.
physician has to confirm it. So a lot of times we'll get a note back saying, I checked with the clinician. Clinician says it's a diabetic ulcer. Uh, okay, I understand that, but we need the physician document or the order that is confirmed by the physician in order to code it as such. And there's still just that lack of understanding out there, but it goes back to intake. Forget the new wounds. The new wounds know that when you call the physician regarding that plan of care, and oh, by the way, I discovered these wounds, or there's these medication interactions, anything that you want to discuss with that physician, But if you've identified new wounds, you get the wound care orders, then create a verbal order with the etiology, and you're good as gold. But a lot of times you don't get the information in intake, and then you don't get the verbal order for the physician. If you happen to get a patient that has been transferred over to their primary care physician, but they haven't seen them for 6 months, you got to get on the phone. You got 30 days to get them in for a face-to-face.
And that's the thing, right? You get 90 days prior and 30 days after the start of care date, whatever that M0090 date is on your OASIS. You get 30 days after that date to schedule a face to face appointment in order to get the information you need. So if you are transferring from a hospital stay to the primary care physician who is very aware of what's going on with that patient, get on the phone that first visit and schedule an appointment as soon as possible with their primary care physician. Let that primary care physician know what you're seeing in the home. That's huge to them. You're literally the eyes and ears and nose, because oftentimes there's smells in home health. You're oftentimes that person for the physician, and so providing them with all that intel that you've gathered and asking them specifically for the things that you need as a home health clinician, that can save you a ton on the back end. And tell me about your past experience, Kelly. I know you worked with K&K. You've worked with K&K for over a year now, but prior to that, you worked with other coding and outsourcing companies, and you had the same dilemma then, correct? I mean, as far as the intake information.
Yeah, and my biggest, what do I want to say, the biggest thing I can give to agencies would be have something set in place for your intake department, maybe a checklist, maybe a list of questions, what they can ask from their referral source to be able to get that right documentation from the start. And then you have all of that information before you send it our way. It's going to help you in the long run. And it doesn't have to be a long list either. It can just be, wounds, like, primary diagnosis, like just all kinds of like little reminders for the intake department. It doesn't have to be anything elaborate. Just something to where they can get everything on the same page and ask the questions that they need to when they're getting that referral.
And you know something I was thinking about in prepping for this meeting? I sometimes wonder if it would not be a good idea to have the coders sit down with the intake people and directly train them as to exactly what's needed. Because they're the ones seeing and are basically constantly having to go back and ask for what they need. So it's like you end up like this between the coders or the intake, and the ones stuck in the middle are the clinicians. So your first line of defense for documentation is your intake. Your second line is the QA and clinicians. Your final line of defense is your coder.
Mm-hmm.
So you don't want everything rolling down to the coder only for them to have to push it back up the hill and say, whoa, not quite yet.
Yeah, and oftentimes time has passed by the time you get through those filters of the intake to the clinician to the QA and then to the coder. There's been a week to 10 days that have passed, and home health is kind of unique in a way that it sometimes boggles my mind, is that we provide care for up to 45 days before we actually get paid. And that means if you see a patient for the whole 30-day episode or 30-day period of care, then you cannot be paid. And if you bill on day 31, there's a 14-day mandatory hold before that claim gets paid. So if you've pushed the can down the road on your intake process 2 weeks to 22 days, say, something in that area, because you hadn't gotten the information on intake, you're having to chase it down, all these things are happening, and then the communication back and forth, I might ask for 10 things and only get 6. I might say I need this, and this on a list, and then I get 6, and then that whole process starts over again. Then I got to go back and ask for that other 4 things that I need. It wears your coders and your QA department out, and then they start allowing things to slip through. They start relaxing a little bit. Can we talk to that a little bit? We, as K&K and outsourced providers, we don't relax because you guys are certified. You're certified coders, and every year you recertify, and you get asked questions about how things should go ethically when you get an order that's not complete. And you have to answer to that. So there's an expectation as a certified coder. What do you think becomes a little bit loose around the edges if you have this constant ongoing issue of your intake being dysfunctional? What kinds of stuff have we seen on customers that we've picked up and seen their process and had to change in their process?
I, I've seen charts take up to 45 to 60 days before the final 485 goes out because of back and forth, asking for documentation, clarification of what the primary diagnosis is, wound care orders, you name it. There's a whole gamut. Sometimes that start of care for us to review isn't assigned for 10 to 14 days.
Mm-hmm.
Then there's an issue, the documents aren't there, or the documents that are there are an unsigned face sheet for a sniff or the discharge summary from the hospital, but they went to the sniff in between, so the referral documents are from the wrong place. So you end up with about another 3 or 4 days back and forth, sometimes 2 weeks before everything is finalized. Even though they're getting prompts, just get the verbal order, get the verbal order. You can go back and generate your written order later. Get the verbal order. And sometimes we can guide, we can't tell them what we need it to be, but we can guide them. It looks like this is what your primary is based on your clinician summary, but you don't have physician documents to support. So, like I said, sometimes it can be upwards of 45 to 60 days before you see that final 485 generated. Okay, so you've already getting paid 2 weeks late.
Mm-hmm. And not only that, you've not given the script to the clinicians. If you don't have a completed plan of care, that should be the script that your clinicians are providing care under. So there's some risk that's inherent in that. I mean, this bleeds down, this intake dysfunction, if you will, it bleeds down into every aspect of the care that you provide. And then on top of that, a TPD might show up, or an ADR might show up, may only ask for 2 charts. And those 2 charts have been sitting in a holding pattern because the job wasn't done on the first day. And that's the thing that just gets frustrating from our perspective. But we know at the clinician level, at the clinic level, at the home health agency level, the QA folks are in battles with clinicians to get the right information. The QA folks are in battles of how to go get those orders when they have no relationship with that physician. They're calling that physician blind to get that information. They don't know what kind of setup your referral folks have with that referral source. And so then there's some animosity from the referral source because then they come back and say, well, why didn't you just ask for this in the beginning? We gave you this referral, you accepted it, and you accepted it without getting the information you needed. And now you're coming back trying to double work us to get this information to you. That it would be maddening, and it is maddening. And so I think that folks need to understand that, and I appreciate Kelly and Jackie getting on here today and letting you know how difficult it is from our side getting that information appropriately. So any other
and the worst thing is the wound care.
Mm-hmm.
How are you providing wound care when you don't even have the orders?
Exactly. And wound care is expensive, y'all. It's expensive.
And I'll throw in there too, what happens if that patient goes back into the hospital and you have a rock and you've not done the start of care yet either. You've got 2 things sitting there. So that's even, more
and your
work,
primary
more work.
goal should always be, everybody on the same sheet of paper, your primary goal should always be, no matter what you're providing, is keeping that patient out of the hospital. That's going to maintain your relationships with the hospital, with healthcare systems, with ACOs you might be a part of, and with your referral partners. They don't want their patients to go back in the hospital, and that's our job as home health. And intake can get expensive. So many of us, having had an agency, I had referral coordinators, we called them patient care liaisons, and they would go out and they were in the scenario of a duck hunter. They were the person with the rifle. They were shooting the ducks, okay? In my scenario, we also expected them to go get the duck and everything that came along with the duck. They didn't just leave the one feather. They try to gather everything up to be as natural and respectful to the ecosystem, respectful to your referral partners. Their job was to go get the duck too. Many of you guys listening to this have duck hunters that think they have a bird dog, right? They're shooting it. It's down. They saw it drop in the woods, but they're not going to get the duck. They're expecting somebody from the agency to go get the duck. And that's a fine proposition as long as you have an intake coordinator or an intake specialist that's aware that that's their job. Their job is to gather the information that the duck hunter went and shot down, right? The referral source went and got the patient's name, the patient's condition. Maybe they were in the hospital, maybe they weren't. All that small stuff. And then it comes back to the intake coordinator to go out and get that stuff. You can set your system up that way. I don't think that many systems are set up that way.
I mean, wouldn't it, and I've heard you say this before, wouldn't it behoove them to identify to the intake coordinator that not only do you need to shoot the duck, but you got to bring the duck in, and then they're paid a certain way?
Exactly. To me, not going and getting the duck by the first person is a primary dysfunction of their job. They're not doing their full job. If you've got it set up where you have an intake coordinator going and getting the duck, fine. They're going and getting all the information you need, but they also need to be savvy enough to examine the duck, right? And make sure that duck is appropriate for what you have in your agency. That's the extra step, right? They need to look at the duck and make sure they have the proper insurance that you guys are providers for. Make sure that they're actually homebound by having a conversation with the duck potentially. All these things, confirming where they live, confirming whether GPS finds their home. That's a simple little thing, but it's a time saver, right? And it saves your clinicians a lot of heartache and headache. So what other kinds of things do you think a specialized intake coordinator could do?
I'm thinking.
Would that be an answer to what the issues you guys have had if they had a specialized, because from our perspective, we're outside the agency. So wouldn't it be cool if we knew who that specialized intake coordinator was in that agency?
To go directly to request the information? Oh yeah, that would be
Yeah.
fantastic. Because that way we would, we'd bypass about 2 or 3 layers and get back to the person that goes and hunts down the rest of the pieces that were left behind. That way it's not getting incorrectly to the QA department and us searching for additional information. Nobody's going to be able to catch the additional wounds. And I keep harping back to wounds, but wounds is the biggest driver. I can say on a daily basis, I am requesting 2 different items for documents all day long, somewhere between 30 to 40 requests from different agencies, different items. It is etiology of the wound and op reports. An op report or a post-op progress note, because ortho loves to preset everything. They already have their ducks in a row, the orders written. I'm doing the TKA on this, and this is what I want done. And here's the H&P. You got it. So you have everything, almost.
Right.
What you don't have is the op report showing that it actually occurred, or a post-op progress note that says post-op day number 1 left TKR, or THR or TKA or amputation, whatever the surgery is. If they had a surgery, you need that op report or the post-op progress note. So that ended up being 3 things, but those I am requesting all day long and tracking. Okay, and 2 or 3 days go by, send a follow up. Have you gotten it in? Half the time, because the agencies are so busy, I go in and look in the EMR, find that it came in 4 days ago.
Yep.
Okay, well, that was 4 days. I'm not blaming the agency. I'm not blaming me in the slowdown. It's just it gets lost
And that's the
in
benefit
the
of
day
having
to
an
day.
outsource. That's the benefit of having an outsourced company that cares. What Jackie just mentioned is that we, for our clients, go back in and search for those orders instead of continuing to bother, in addition to, not instead of, in addition to continuing to notify you of what is missing in your orders list, where the exact thing that you need to request. And from K&K, and I can't speak of the other outsourced providers, but K&K, we're going to give you a specific thing that we need when we do an audit of your information. It's going to say, I need information, etiology on the wound on the left lower extremity that's this size, that has been treated with this. We're going to give you everything about it. So all you have to ask is the one question. But I still think that we have more to talk about. And I want to do a part 2 to this webinar or this podcast, because we've identified the problem. Now we got to fix it. And we got to give really good recommendations on how to fix it. And teaching agencies beyond our partner agencies, but agencies everywhere who listen to this, that if you can get this part right, you have saved yourself so much time and money, and it's a value gain. And we don't have any time to waste, because we have these plus 500 codes coming in on October 1st that are going to have to be implemented, and they're going to have to come in the orders that are coming. And it's always been a little bit of chaos during that time in agencies when we get new codes. It's been a long time since we've gotten this many new codes. And so I just kind of warn everybody that you need to be prepared for that October 1st. Some of them go into effect October 1st, most of them on January 1st. So it gives you a little bit of a time to train your staff and or upgrade your education for that. So you guys okay with doing a part 2? Because we're getting a little long in the tooth on this one. All right.
Yeah, because we can take it many different avenues.
And I'm going to bring in Cindy Kraft on part 2, because she's way better in the processing situation and is a very good communicator when it comes to process. So stay tuned for part 2. Thanks for listening to this episode, and thank you, Jackie. Thank you, Kelly, for your time and your information. We'll have you back on part 2 soon. And those of you that listen to us, thank you for being a subscriber, and be safe out there.
Hi, everybody.